Infants, preschool children, adolescents, and women of childbearing are at the greatest risk of developing iron deficiency anemia, which we should be aware of it. We understand delayed clamping, meaning thereby 1 minute. And 1 minute is a very long time during that time, but it can improve the iron status of the baby and reduce the risk of iron deficiency anemia. Secondly, the GI bleeding like portal hypertension with a bout of even the 1 hematomesis, child will develop the severe anemia. But yes, chronic anemia, iron deficiency anemia in adolescents or older children, you will be able to appreciate this type of the cholericia. And cholericia is a very characteristic of iron deficiency anemia, which all of us should be knowing.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Friends, welcome to this our evening session. And I am going to talk to you today a very basic subject, and that is the iron deficiency anemia in children. I'm sure that every medical person of this country specifically should know in details regarding the iron deficiency anemia. Reason is it is a nutritional anemia and is the most common type of anemia found clinically in children. The deficiency of main macronutrients required for the synthesis of hemoglobin, like iron, folic acid, and vitamin B12 are grouped under nutritional anemias. Among all these, iron deficiency is the most widespread macronutrient deficiency. It is estimated to affect 1/3 of the world population, out of which 90% cases are from developing countries. And therefore, I said that the medical person, any specialty of this country should be well versed of iron deficiency anemia. Infants, preschool children, adolescents, and women of childbearing are at the greatest risk of developing iron deficiency anemia, which we should be aware of it. Let me put the important facts which are very essential for all of us to know. That a full-term newborn infant contains about 0.5 gram. Roughly it comes to 75 milligram per kg of iron compared to 5 gram of iron in adults. Infants and young children should continue to absorb 1 milligram of iron daily to reach the adult level of stores of 5 gram. Now 1 milligram of iron should be absorbed daily to maintain the positive iron balance in the childhood. Reason is less than 10% of dietary iron is usually absorbed. Less than 10% of total whatever the iron you take it. And a dietary intake of 8 to 10 milligram of iron daily is necessary. The surprise is that iron deficiency is common despite evidence of iron in the Earth's crust because of factors like poor dietary intake, impaired absorption, even blood loss leading to insufficient iron for the RBC production. I think these basic facts are very interesting for all of us to know. We should know that which are the rich sources of dietary iron so that we can advise to the patients and even children and their parents. Meat, eggs, particularly the dates, jaggery, millet and ragi, green leafy vegetables, and sprouts. These are some of the rich sources of dietary iron. Please remember that though the breast milk contains small quantity of iron compared to the other milks, the bioavailability of this iron, that is the lactoferrin, is about 50 to 70%. And hence, ultimately at the end result, it is adequate for the first 6 months of the life. Very important message which I want to convey on this stage to all the listeners, that please keep in mind the delayed clamping of the umbilical cord. We understand delayed clamping meaning thereby 1 minute. And 1 minute is a very long time during that time. But it can improve the iron status of the baby and reduce the risk of iron deficiency anemia. Therefore, I think all the obstetricians of this country and all the pediatricians and neonatologists of this country should know very basic, very simple, very important first step for prevention of the iron deficiency anemia is the delayed clamping of the umbilical cord, that is after almost 1 minute of the birth. Please remember that some of the factors are retarding the absorption of iron that we have to take care. Which are they? Alkaline pH, phosphates, phytates, bran, calcium, tannins, antacids, cobalt, lead, and therefore we have to take care that whenever you advise for some iron therapy, these factors should not come on the way, otherwise they will retard its absorption and availability of iron will decrease. Now let us check that what are the common causes of iron deficiency anemia. Please, mainly they are concerned initially with the decreased iron stores in the form of the preterm babies, small for dead babies, and even the twins. They are always at loss of the iron store. Which are the factors affected with the decreased intake? There is lack of breast milk. Please remember why we are insisting so much regarding the breast milk. And you know that just after the few days we are going to celebrate World Breastfeeding Week. That is 1st August to the 7th August, first week of the August. Why we celebrate this week? We want to convey these messages to the public as a whole, and more so particularly the paramedics and medical people. And therefore insist the breast milk first 6 months exclusively, later on continue up to even the 2 years. And it has the major role in prevention of the iron deficiency anemia. Then the delayed introduction of the complementary feeds is also equally responsible. The reason is you know that after the 6 months, milk is not sufficient diet for the children. And here please understand, it's not winning, it's a complementary feed. Continue the breastfeeding and add some other family diets and select the iron rich so that they don't develop the iron deficiency anemia. Some of the foods are very poor, that also we should keep in mind. Very important factor, I will say, responsible for iron deficiency in the infants and young children in our country is the top milk, particularly the cow's milk. How? Number one, there is a lower bioavailability of iron compared to the breast milk. Bovine milk is rich in the calcium. Again, already we discussed that it retards the iron absorption. And cow's milk allergy, which can cause even the hidden, unnoticed GI blood loss, which may be responsible for the chronic iron deficiency anemia. And please remember, in our country, somehow I will say, society, it's a culture that every child should take the milk. If some children are not ready, you must have seen that the parents, grandparents, they are insisting for the milk. And many a times they remained mainly on the predominant milk for a pretty long time, 1 year or beyond that. And then what happens? They don't get the iron and develop the iron deficiency anemia. Even malabsorption is also a equally responsible factor, particularly in the older children, like celiac disease due to malabsorption, chronic diarrhea due to any reason, giardiasis, cow's milk allergy, already which we discussed, chronic infections like HIV, tuberculosis, or even any GI surgery. Ultimately, all these factors lead to the malabsorption. Sometimes even the loss of the blood. Particularly, I will say in the preterm babies or neonates, and in the pediatrics even, repeated blood sampling for the investigations, which we never consider in our, I will say, calculation. But it's a big, big factor. Secondly, the GI bleeding like portal hypertension with a bout of even the one hematemesis, child will develop the severe anemia. Some of the drugs like NSAIDs, non-steroidal anti-inflammatory like ibuprofen, even the mefenamic acid, nimesulide and others. Please remember in our country, hookworm infestation is very common factor responsible for iron deficiency anemia. Reason is each worm causes 0.3 ml of blood loss daily. Cow's milk protein allergy, which already discussed, which can cause the loss. Even some polyp, yes, Meckel's diverticulum, and even menstruating girls, adolescent girls. Malaria, it will cause the hemolysis, peptic ulcer, bleeding diathesis, hemangioma, inflammatory bowel disease like Crohn's disease, and even the ulcerative colitis. So friends, I think this is very important, which I mentioned, the common causes for the iron deficiency anemia, and that I think we should keep in mind. Even there is an increased requirement at certain stages, physiological increased requirement. And if you don't provide, they go for the iron deficiency, like preterm babies, small for date, adolescent girls, particularly during the growth spurt, during pregnancy, lactation, yes, there is an increased requirement and accordingly, we'll have to supply the iron. Let us say that what are the clinical manifestations of iron deficiency anemia? So that as a clinician we can pick up. And that is the, please remember, the most I will say peak incidence for the iron deficiency anemia is between 6 months and 3 years. Very common. Followed by adolescent girls. Adolescent as a whole, more common in girls. And pregnant and lactating mothers. So please remember these groups. They are vulnerable to develop this iron deficiency anemia. So age is very important. Look at the age of the patient. Second most common manifestation is the pallor. But please remember that pallor does not mean always iron deficiency anemia. Most commonly, yes, but sometimes pallor appearance may be in a case of hypoperfusion, in some critical patient, even hypoxemia, generalized edema like nephrotic syndrome, hypothyroidism. All these patients apparently looking pale. And if you go for the estimation of hemoglobin, may not be that poor. And therefore, as a clinician, we should be aware that is it due to this iron deficiency anemia or something else, pallor. And then what are the sites to be checked for pallor? Check at the lips, tongue, conjunctiva, particularly the bulbar conjunctiva, palms and nails. Even simply from the examination, good clinician can say the degree of anemia. Suppose there is no pallor apparently, but the child is pink. We can say that's no anemia. Particularly when the palms are pale. That means there is some anemia that comes to moderate anemia. But even if you look at the palmar creases, they are also pale. So as a clinician, we should know that what I should check. Not just pallor palm, but look at the creases. If the creases are pink, palm is pale, that means fairly good hemoglobin. Anemia may be moderate. That around you can say that 5 to 7, 8 gram percentage or so. But once palmar creases are pale, that is severe anemia, that means hemoglobin is less than 5 gram percent. What I mean to say, friends, what I want to share with you, simply just my clinical examination as a master clinician, I will say, you can say that what degree of anemia, not just anemia alone. These are the various pictures which I wanted to show. I'm sure that you are able to appreciate on this left side these various, I will say, appearance of the tongue. Upper one is normal, middle one is mild pallor, and you can see this lower picture. Severe pallor and even loss of the papillae. That indicates severe pallor. So I think this is the thing which I wanted to show. This is normal, mild pallor, severe pallor. Similarly, I think if you see even the nails, pallor, but here severe pallor you can see. Even you can appreciate the hyperpigmentation of knuckles. And that indicates even the vitamin B12 deficiency or megaloblastic anemia. I think this picture I want to show you how to see the palm. Compare the palm of the normal person. You can see the left side, it is the normal pink. Right side palm is quite pallor. And the lowermost picture I want to show. Look at the nails. They are not normal convex. They are not even just flat, but they are concave. And that what is says the koilonychia. Somehow koilonychia is not so common in children compared to the adults. But yes, chronic anemia, iron deficiency anemia in adolescents or older children, you will be able to appreciate this type of the koilonychia. And koilonychia is a very characteristic of iron deficiency anemia, which all of us should be knowing. What are the other manifestations? Even if the child is complaining of the easy fatigability, mother will complain that now he does not like to play. I think that's the complaint. There may be the decreased appetite, anorexia. Younger children, even I will say infants or 2 to 3 years children, they become the irritable. Cognitive functions are affected. They are not able to, even sometimes scholastic performance in the school is affected. And therefore scholastic performance from the school also you may get the idea. Short attention span, particularly I will say even adults. They complain that not able to keep the constant attention or impaired mental and the motor development in the children. Glossitis, which earlier I showed you, even there may be the stomatitis, and even esophageal web development may lead to the dysphagia. Very important with this dysphagia in the very young women. One syndrome is known, more so in the adolescents or I will say young women, there is Plummer-Vinson or Patterson-Kelly syndrome. Here, along with this severe anemia, iron deficiency, there is a difficulty in the story of, I will say, that syndrome. There may be the pica in children. What do you mean by the pica? Irresistible desire to eat non-nutritious substance. There may be the desire to eat the ice, what we call the geophysia, sorry, that is the pagophysia, geophysia, that means earth or dirt, and amerophysia, that is the starch. So these type of the different desires to eat, what we say pica, may be the manifestation of even the iron deficiency anemia. As I was talking regarding the colonuria, before that, that may be the flattening of the nail, what we say the platinikia. Please, friends, remember if the chronic anemia, iron deficiency, which has long standing, may present with a mild splenomegaly, which should not be mistaken for the hemolytic anemia. Even sometimes frontoparietal bossing, what we say caput quadratum in thalassemia, that type of the picture may be seen in long-standing severe iron deficiency anemia. So I think as a clinician, please keep in mind that average, always presence of spleen and even the frontal bossing should not be mistaken as a thalassemia. Of course, we'll have to rule out. If it is ruled out, it may be the long-standing chronic iron deficiency, and that you can check with other investigations. There may be the increased susceptibility to the infection, yes, due to the depressed immunity, and severe anemia patient may present with the congestive cardiac failure. Many times you may get the patient with 2 gram, 3 gram, 4 gram hemoglobin, and child is moving, walking around. Even pregnant women, we get this was the picture in our country. Reason is, here is the chronic anemia. And chronic anemia gives some adaptation to the child and therefore may not go for the CCF. But anemia due to the short duration may present with the CCF. One more point I want to bring to your notice, that the anemia with the clubbing. This is contradicting. Earlier I talked that there will be the colonuria. That is the concavity. Here, this is the convexity and other features of clubbing. Please remember there are very few conditions in the pediatric, and if you get it, it becomes a very important clue for the diagnosis. That refractory iron deficiency anemia with clubbing, with suppose some chronic diarrhea, I will say you can say it's a celiac disease. Sometimes with other features, it may be inflammatory bowel disease like Crohn's disease, ulcerative colitis. Yes, bacteroendocarditis within the short time can present with this anemia and clubbing. Occasionally, arteriovenous fistula may present with anemia and clubbing. Anemia is a risk factor. Certain conditions may be predisposed by the iron deficiency anemia, like breath-holding spasm, febrile seizures, and even the severe stroke. Reason is that due to the chronic iron deficiency anemia, there is a bone marrow stimulation in a case of chronic anemia. And then there is a thrombocytosis. Thrombocytosis leads to the thrombosis in the vessels, may result in a case of, I will say, stroke. So friends, I think this is very important, I will say important association of iron deficiency anemia with these conditions. Once clinically you decided it is iron deficiency, what investigation should be performed and how will you interpret? That is very important. First, always go for the CBC. Not I will say just CBC, complete hemogram. What we mean by even the indices. Here hemoglobin is reduced, RBC count mass is reduced, MCV is low, MCSC is low. And very important point, always look at RDW, red cell distribution, which is always increased. Please remember, friends, CBC provides a lot many information. Just asking for the CBC is not sufficient. And along with the CBC now, that is the hemoglobin count and differential counts and platelets count, they are providing lot many informations. They give all the indices. They even calculate the RDW. RDW indicates various size and shapes of the cells. And if it is more than 15, that is considered the increase, which favors the iron deficiency anemia. WBC may be normal. Platelets, as I said, may be normal or sometimes increase and leading to thrombocytosis. Please, friends, remember that in hematology, peripheral smear examination is very, very important. More so particularly in anemia. Look at the RBC morphology. Not only RBC, look at even the neutrophils, platelets. You know that even the anemia and neutrophils are hypersegmented. That indicates this mixed picture, that is even the iron deficiency and megaloblastic anemia. Even the shape of the RBC, that also provides lot many information. What I want to convey, actually peripheral smear examination itself is one lecture for 60 minutes. But I want to insist and emphasize that look at the details of the peripheral smear examination. You know, reticulocyte count is very important. Hematologist friends say that reticulocyte count is for peeping the bone marrow. That indicates that how the bone marrow is functioning. Usually the reticulocyte count is increased due to the increased bone marrow function. And even if it decreases, it indicates that something is wrong with the bone marrow. So friend, what I wanted to convey, each sentence, each word is very important for the exact interpretation for the iron deficiency anemia. Please just don't see, I will say, just with a cursor look. Go for the details and interpret it very appropriately. Serum iron, yes, it is going to be reduced, but please remember, serum iron is not the good investigation because it gives a very wide variation. But yes, we can do. Total iron binding capacity is very important. And if more than 350 microgram, that is raised. Transferrin saturation is less. Ferritin is very sensitive and very important investigations for iron deficiency anemia. Suppose if you have to perform only one investigation for iron deficiency, please go for the serum ferritin. The only one point of the precaution for interpretation which I want to convey. Serum ferritin should not be interpreted in the presence of fever or the infection. The reason is in the presence of any inflammatory condition. Serum ferritin works as an acute phase reactant. So it is increased. And therefore my interpretation for iron deficiency anemia may be wrong. So it's very important that how the serum ferritin level should be interpreted. But in the favorable circumstances, serum ferritin is the most sensitive, more reliable, and I will say I will go for only investigations. It's a gold standard for diagnosis of iron deficiency. There may be depletion of stable iron if we have done the bone marrow in a case of iron deficiency anemia. Serum iron, as I was talking, maybe even the various considerable diurnal variation, even the depends upon the dietary intake, may be affected due to the various conditions. And therefore, in the one sentence, the message if I want to convey, serum iron is not a reliable test for the diagnosis of serum iron. But yes, if you have gone, then you should be able to interpret properly. Serum ferritin, which I was talking, is a gold standard test. It is a highly specific and very good sensitivity test. Even sensitive laboratory index of iron status will be also known. Serum ferritin may increase in inflammatory conditions, as I was talking, like collagen disorders, chronic infection, malignancy, chronic liver disease. And in these circumstances, ferritin is raised as an inflammatory marker, and therefore iron deficiency anemia may be missed. And therefore, if CRP and serum ferritin together, if you have done, and both are raised, consider them as an inflammatory marker. And if ferritin level is not reliable to assess the iron status in this condition. How we can go for differential diagnosis of iron deficiency anemia, whether it is iron deficiency, anemia of chronic disease, or thalassemia trait, which are very difficult sometimes to differentiate. We can go for the MCV. Usually it is decrease in the iron deficiency compared to other two. RDW, as I talked, is increased in almost every condition, but more so in the iron deficiency. Red cell morphology is very important for refractory examination. Microcytic, hypochromic, anisopoikilocyte is the characteristic of iron deficiency. Normocytic, normochromic in spite of low hemoglobin, that means chronic disease. And thalassemia trait again, very difficult to differentiate from the peripheral smear examination. RBC mass may be decreased except in thalassemia trait, may be normal or even sometimes increase. Serum iron is again decreased in chronic disease as well as iron deficiency, which will be normal in trait. The IBC is increased, very significant iron deficiency. Transferrin saturation is very important. Ferritin, as I said, is gold standard, decrease in iron deficiency anemia. If you are not clear, we can go for the HB electrophoresis, particularly to differentiate it from thalassemia trait, where particularly HbA2 band will be raised, more than 3.5%. Marrow hemocysteine you can do, so I'm sure that these points will differentiate the three conditions. Once you confirm this iron deficiency with your clinical diagnosis and investigations, what treatment we will offer, and particularly the iron therapy. Please remember, oral iron therapy is the ideal treatment. Don't jump for the injectables. Dose is 3 to 6 milligram. Range is wide. But please remember that nowadays lower dose works very well. And therefore hardly it requires to go beyond 3 to 4 milligram per kg per day. Hemoglobin level is usually reached in 3 months. And it should be continued for another 2 to 3 months to build up the iron store. And friends, therefore remember that the total duration may be 4 to 6 months. Various oral iron components are available, but better absorbed is a ferrous than the ferric iron. And ferrous sulfate is containing 20% of elemental iron. Please remember, the dose 3 to 4 milligram per kg per day I said is the elemental iron. And therefore in every preparation, we'll have to know what exactly the elemental iron is there, not the salt, whatever is mentioned on the product. Ferrous gluconate, 30% of elemental iron. Ferrous fumarate, almost the same. Ferric ammonia citrate, 18%. And it is most commonly used as the ferric salt, so may not be probably of our choice. Iron polymaltose complex is a novel iron preparation which contains non-ionic iron polymaltose in a stable complex, but not, I will say, so efficacious, so we should not be misguided. Carboxyl iron is again a small particle preparation of highly purified metallic iron. Safe, lesser side effect, much less toxic than other ionized forms of the iron, but cost more. Colored iron is a readily available iron preparation. Hardly any data is available, and therefore we don't use. Iron in the form of hemoglobin was available once, is not useful, very large volume is required, and does not, I will say, work the way which you are expecting. So it should not be of our choice. Entry-coated some tablets may be expensive, but probably may disintegrate in the stomach and hence the absorption may not be adequate. Slow-releasing preparations are available, may improve the absorption and lesser side effect. Some sprinkles are now devised by the UNICEF so the children can accept it. Iron should be taken as empty stomach. Please remember, either the 2 hours before taking the milk or after, any possible. If you are able to manage single dose, it's good. If not, at least you can divide into doses. Phytates, calcium or the tea should be avoided because they retard the absorption of iron, which already we discussed. B12 and folic acid are commonly affected deficiencies, so they should be supplemented with the iron. Side effects, yes, nausea and vomiting. Some children may develop diarrhea, so that you can give even the less of the dose. Yes, constipation is also known. Abdominal discomfort may be the complaint. And ferrous salts are having the high incidence of GI side effects, almost 1/4 of it. Iron absorption is maximum during the initial phase of therapy, and it declines from 14% in the first week to 7% in the later part of the therapy. Parenteral iron therapy, again, it has come in the practice. Many years back we were using, but the preparation was not good, having the very high side effects, anaphylaxis-like, and we left it. But now good preparations are available with exact indication you can use it. Which are the indications? Severe intolerance to the oral iron, GI bleeding aggravated by the oral iron like portal hypertension, preoperative, in urgent surgery, or malabsorption some syndromes. We may have to go for parenteral iron. Dose is to be calculated at iron in the milligram is equal to weight in kilogram into hemoglobin deficit into 80 upon 100 into 3.4 into 1.5. Roughly very simple, weight into kg into the hemoglobin deficit into 4. So I think this will be required the total elemental iron. Preparations are available, iron dextran complex. As I said, in the past we were using, which is not safe and now no longer preferred, probably not available even. Iron sucrose, yes. Sodium ion glucose, ferroxylitol, ferric carboxymaltose, again not approved for use in the children. Side effects are there like skin rash, arthralgia, myalgia, anaphylaxis now, which is very rare, but that we should keep in mind. Always hospitalization when the anemia is very severe, hemoglobin is less than 5 gram, or CCF, or even with malnutrition. PCV transfusion is now rarely needed. Please avoid the transfusion as far as possible. Except severe anemia with CCF or hemoglobin is less than 4 gram deciliter, particularly with the malnutrition. Or if there is the ongoing blood loss due to some fracture or portal hypertension or even Meckel's diverticulum, then we'll have to give. Otherwise, we want to avoid. Once you start the iron therapy, the response is seen within the very short time, even in 12 to 24 hours. There is a replacement of the intracellular iron. Therefore, subjective improvement, person feels better. Children, irritability decreases. Within few hours, even there is increased appetite. Even serum iron, if you do natural, it is going to be rise. Within, I will say 36 to 48 hours, if you see in the bone marrow, there is responses there, and there is erythroid hyperplasia. But a very important point which even people ask in the exam, that is reticulocytosis, which will be seen in 48 to 72 hours. And the peak for the reticulocytosis is in the 5 to 7 days. 30 days, increase in the hemoglobin level, and it is said 0.1 gram per deciliter per day. Yes, increase in the MCV, increase in the ferritin level, and 1 to 3 months replacement of the stores can be seen. Please remember, this is very important statement which I want to make it. As a clinician, if you don't go for even the investigations or even in spite of the investigations, if there is no clarity, there may be in a case of thalassemia trait or iron deficiency anemia, if you start the iron therapy and increase in the hemoglobin more than 1 gram per deciliter after 1 month of iron therapy, is usually the most practical means to establish the diagnosis of iron deficiency. No response to the iron therapy, then suspect something else. That is very important message from this bold statement. That if you don't have the clear diagnosis, start the iron therapy and check the hemoglobin later on. And that if iron deficiency, there will be increase of more than 1 gram per deciliter after 1 month of iron therapy. That is very important, I will say, clinical clue. How we can prevent it? Please remember, for the prevention, this country requires the prevention. Exclusive breastfeeding for the 6 months is very important intervention. Every baby should get the exclusive breastfeeding for the first 6 months, later on continue up to 2 years along with the appropriate complementary feeds. Timely introduction of complementary feeds is also very important. Iron supplementation for preterm and low birth weight babies should be started early from 2 months of age. Please restrict the cow's milk or bovine milk consumption somehow, which is traditionally in our society encouraged. So explain them. And iron-rich diet like dates, jaggery, millet, ragi, and green leafy vegetables should be encouraged. Even Government of India has iron folic acid supplementation in the various age groups. I just kept the table, easily available, I will say in your Google also. Check it and remember that this program is there in Government of India. When there is, we call it the refractory iron deficiency. And it is a frequent, I will say, in our practice. So we should be aware of it. But when there is a failure to respond to the therapeutic dose of iron, that is up to 6 milligram, administered for at least 4 to 6 weeks. In a 1.5 month, if there is no response to in the form of the increasing hemoglobin, that's the time to say the refractory iron deficiency anemia. But before evaluation, please check for compliance, which is the most common reason for poor response. Because child does not like, child vomits out, let's stop it. GI intolerance, yes. Dose, check it very appropriately, with preparation, what is the elemental iron. Even if requires, you can go for intermittent administration. Dose, as I said, is very important to check it. And which formulation is also very important. Whether they are given with diet, that is also very important, or encouraged for the good diet, like less milk and iron-rich food should be avoided, should be encouraged. So with this, let me take to you some of the cases. I think I will take some more 5 minutes or so. This was the 9 months male, pallor noted during the vaccination visit. Firstborn child, weight was 2.7. It was breastfed plus cow's milk, almost 1200 ml per bottle. And rest of the examination, if you say marked pallor, no jaundice, no cyanosis, liver and spleen okay. Rest of the examination was non-contributory. You can see the growth of the child. Head circumference is above the normal, weight is above the normal, height is good, but iron deficiency anemia. And that on investigations, hemoglobin 6.5, RDW you can see it is raised. Already iron supplementation was going on for 3 months, but there was no response. Dose was also right. And therefore, what we did, analysis, a 9-month-old child, weight is good, severe pallor, feeding cow's milk 1200 ml per day, that was the reason. And no response to the oral iron therapy. That is the cow's milk and refractory iron deficiency. We know it's a poor source of iron. Large quantities, that means more than 700 ml per day, will replace the iron-rich food. Even cow's milk protein allergy can also cause some loss. And therefore, in this case, cow's milk was eliminated, responded very well to the iron. So these type of things we'll have to check it. Another 13 years old child was referred to us for not responding to the iron therapy. Friends, here if you check it, hemoglobin was low, platelets on the higher side. And in this patient, you can see height and weight both are affected. When we went for the investigations, hemoglobin was low, count okay, platelets okay. And with these investigations, you can see, which I was showing, that iron deficiency with clubbing. And therefore, it was very classical of celiac disease. So celiac disease may be the reason for the refractory iron deficiency anemia. Another girl presented for the same iron deficiency anemia, but what I wanted to show, you can see this hyperpigmented knuckles. You can see the MCV is raised. Therefore, along with the iron, there was deficiency of even the vitamin B12 and folic acid. It was confirmed by the bone marrow. Here it was 5 years old female, presented with the anemia, hypochromic microcytic, not responding to oral iron, no hepatosplenomegaly, but you can see iron 120, total iron binding capacity in ferritin is on the contrary raised. And later on we went for the HB electrophoresis, turned out to be the thalassemia trait. So these are the things which will be presenting as not responding to oral iron. Again, this was 6 years old child, persistent pallor, cough with difficulty in breathing. 6 PCV was given to this patient with a severe anemia. You can see these vitals of mild tachycardia, tachypnea, systolic murmur, hemoglobin 4.6, count normal, platelets normal. Other investigations were normal. Bilateral pulmonary infiltrates were there. We went for the CT scan and turned out to be even the bronchial lavage was done. That was a case of pulmonary hemosiderosis. Rare, I will say, not so common, but this can also be one of the reasons for refractory iron deficiency anemia. This was a 2-month-old child, referred for severe pallor. 1 PCV was given 15 days back. There was the history of death of 2 siblings in infancy due to the severe pallor. You can see severe pallor, tachycardia, tachypnea, liver and spleen, both were enlarged. And when we went for the hemoglobin was 6.5, hematocrit 30, HB electrophoresis, fetal hemoglobin, G6PD, direct Coombs test, Oswald fragility test, everything was within normal limits, so all the conditions were ruled out. Iron 133, I binding capacity 141, that was low. No response to the oral iron therapy and folic acid. Bone marrow was done, turned out to be the sideroblastic anemia. Again, not so common, but yes, one of the reasons for not response to the oral iron. This was 8 years female, generalized weakness, decreased appetite, excessive weight gain, and pallor. puffy face swelling over the legs. Friend, to cut short the story, that was the case of hypothyroidism. What I want to share with you that this can also present. Even lead poisoning can also present as the not responding iron therapy. So this is very classical approach to macrocytic hypochromic anemia, that very simply you can go for the therapeutic. Deworming is also very, very important, which we should keep in mind. And good compliance, proper dosage, proper preparation, whether they are taking properly, proper investigations, everything should be done for finding out the cause for the refractory iron deficiency anemia. Friends, what I want to share with you from this discussion, please remember, iron deficiency anemia is the most widespread macronutrient deficiency. Infants, preschool children, adolescents, and women of childbearing and menstruating girls are at greatest risk of developing iron deficiency anemia. Lack of breast milk, predominant milk diet, iron poor diet, malabsorption, chronic blood loss, particularly from the GI tract, and increased requirement of iron in specific conditions are main causes of iron deficiency anemia. Most cases detailed history and thorough examination is sufficient. Very basic investigations like CBC, indices, peripheral examination, even the count, serum ferritin level may be performed, it requires. And oral iron therapy is the most ideal treatment. Parenteral iron therapy, find out the exact indication, appropriate preparation, then we should use it. And increase of hemoglobin more than 1 gram after 1 month of iron therapy is most practical means to diagnosis iron deficiency anemia, and it is right. Breastfeeding, delayed cord clamping, iron-rich diet are simple measures for prevention of iron deficiency anemia. Refractory iron deficiency may frequently encounter. Once you are giving the 3 to 6 milligram elemental iron per kg per day, and after 6 weeks also there is no rise of hemoglobin, that is the time to suspect refractory iron deficiency. Before any further investigations, go for the good compliance, dosage, formulation, everything should be checked. Deworming is also very important. True iron refractions may be in the setting of ongoing losses due to the GI, pulmonary bleed, malabsorption, and some genetic disorders. But in the nutshell, detailed history, thorough clinical examination, and methodological approach with appropriate investigations is the master key to clinch the diagnosis and to manage the patient of iron deficiency anemia. Please remember some of the do's and don'ts. Don't transmit the PCB, very important, unless there is cardiac failure. Don't do iron studies in typical class. Do iron challenge study. Don't prescribe unnecessary calcium. Don't give the calcium within 4 hours of the iron, very important. What we should do? Deworm every child, especially with anemia, at least twice in a year. Stop water feeding, particularly this milk diet. Explain about the protein intake. Ensure compliance, completion of iron therapy. Prescribe prophylactic iron to every preterm and small potato baby. Thank you very much. I think what I wanted to convey, very common topic. I have taken a little bit more time, but purposefully I wanted to convey the exact messages. And what I am thinking that not I will say only pediatrician, but every medical person, whatever your specialty, every your patient, your adult, female, male, child, everybody has some degree of anemia. And if you pay the attention, just to correct it methodologically, there is significant, I will say, improvement in the performance of the child and even the person, even in the adults, in his daily working. Thank you very much. Thanks a lot.
What are the preferred iron salts for oral preparation and dose?
I think, as I said, best one is the ferrous but even the ferrous sulfate is considered the one of the best, and where the 20% of the elemental iron is available. But even ferrous sulfate, ferrous gluconate, ferrous fumarate, any of the three preparations, if somebody is using, I will say more or less the same. In every preparation, please check the elemental iron and calculate a dose of 3 to 4 milligram per kg per day. And I'm sure that that would be the good preparation and good doses. The only
Yes.
thing, the duration should be minimum 3 to 6 months.
Yes, sir. So we have a similar question by Dr. Shivam. I think you've answered this.
Yeah. I will say ascorbate and fumarate also fairly good. Hardly any change on it. The only thing that the fancy preparations which are available in the market, we should not be wrongly attracted. That's in, I will say, one sentence which I would like to answer.
Yes, sir. Thank you. So there's another question here by Dr. Sudarshan. At what age is iron deficiency anemia most prevalent?
Yes.
And how do we differentiate? There is one more question. How do we differentiate it with IDA with thalassemia, since
Yes,
they're in a
yes.
similar age group?
Good question. You know that the most common age for the iron deficiency, as it can occur at any age. At any age, and even it is seen in the practice. But most common in the pediatric practice, if I talk, after the 6 months, provided child was on the breastfeeding. Because breastfeeding is a good source for the iron, and usually they don't develop the problem. 6 months to 3 years, where probably appropriate complementary feeds is not started, they are vulnerable. Later on, age comes of the adolescents. Because all of us know that adolescents, they have the different dietary habit. They stop to eat at home, and whatever they eat outside, poor sources of iron. Second thing, particularly the girls, that is the age for their menstruation, so loss is also there. And during that time, if not appropriate iron is intake, they are vulnerable to develop the iron deficiency. Later on, pregnancy and even the lactation. These two phases, because there is an increased requirement. So if you look after, these are the common, I will say, age groups where iron deficiency anemia is common. How to differentiate from thalassemia? I think for thalassemia major, there will be no confusion, because severe low hemoglobin, enlarged liver spleen. If you go for the HB electrophoresis, there will be the raised fetal hemoglobin, diagnosis is obvious. But when the confusion comes from the thalassemia trait, you know that thalassemia is divided in three varieties: thalassemia major, thalassemia intermedia, thalassemia trait. Even thalassemia intermedia also, we clinically usually are able to differentiate because they require the blood transfusion. There is enlarged spleen also. But trait, we cannot. Reason is on only clinical ground. Because most of the times they remain the low hemoglobin, not so low, I will say mild to moderate anemia. Spleen may not be there. And even if you go for the investigations like peripheral smear indices, almost both will be the same in iron deficiency and thalassemia trait. So here, most important investigation is the HB electrophoresis. What you will look into the HB electrophoresis? Because fetal hemoglobin also may not be affected. Look at the HbA2 band. And HbA2 band will be very prominent, more than 3.2% in adults or in older children. That is the, I would say, point for the diagnosis of thalassemia trait. Many times in the pregnancy, first time, because the lady is anemic, obstetrician is giving the iron on follow-up, there is no improvement of the hemoglobin. They go for the HB electrophoresis and they come to know, oh, she was suffering from the thalassemia trait. So I think that's the thing that how we can differentiate.
Sir, I think there's only one question that we haven't covered here is many patients complain of gastric irritability if they take iron on empty stomach. What is your expert opinion on this?
Absolutely. I think it's a
When should
practical,
iron be given?
yes, practical question. Not so simple the way in which I have described, or I will say advise in the lecture. In the practice, it's difficult, I understand. And I think some good clinician must ask the question. You know, we advise for the empty stomach for the good absorption. And that's for what I said, if the child is able to tolerate, as far as possible, go in the single dose. And then what is the good time? I will say before going to the bed, at night, before going to sleep. Because I will say evening dinner is given early, wait for 2 hours at empty stomach, because that will be almost empty stomach. Our purpose is solved. And if you give the iron, child will go to the sleep. Mild gastric disturbances will not be noticed. I would say that's a good management. But sometimes really suppose gastric upset is severe, naturally we cannot avoid. In that situation, go for divided doses. 1 dose morning, 1 dose evening. You can find out appropriate, convenient time to the child and the mother. And you can, I will say again, divide the dose. If you divide the dose, I will say tolerance becomes good. And very few children, even whatever the measure we take it, suppose some children is not able to tolerate, even tell them that even after the food also they can take. No problem. Whatever the absorption is, then acceptable. And third, even if I say all the measures we fail, even when the child is not able to tolerate at all, and iron is required, that becomes the indication for the parenteral iron. Usually we don't advocate, but in this situation, I will say once a while, once or twice in a year, if some practitioner has to do, I will say it is totally scientific and justified. But the steps, usually in the evening before going to the bed, or even the divided in 2 doses, or even after the food, last resort is the parenteral iron. But we can solve it.
Okay, sir. Thank you so much for this presentation and also for taking so many of our questions. We've covered all the questions right now, and if there are any more questions, I will.
Yes. Even they can put on the, I will say my message or WhatsApp. You can provide the number. I don't mind. I'll be very happy to answer.
Yes, sir.